That was easy. I was trying to figure out what do I need to click to get my presentation up, and there it is. So I'm Mandi Pratt-Chapman. I'm happy to be here today, honored to be presenting to you. I have quite a bit of information, so I tend to go quickly, but I will be happy to clarify or take questions later. Oh, I'm having a Melissa problem. Which green arrow? Let's see. Nope, that's the pointer. Oh, there we go. Okay, so I wanted to start. That wasn't very nice, was it? I wanted to start with acknowledgments. So some of the work that I am going to be talking about was modestly funded by the AONN Foundation. They've been pretty flexible in the past when we've needed resources, and the competency development process that I'm going to describe benefited from the review of many national experts, including people on the ground, educators, researchers. So these are the people that I'm indebted to for this work. I want to point out a couple of things in terms of learning objectives. I'm hoping that you'll walk away with a greater sense of what's been happening in workforce capacity development, access tools. I'm a very practical and applied person, so I like to make sure that there's always tools available for people to use. And also, time permitting, identify a few implementation factors for success. I also want to point out that these learning objectives have words like identify, access, and consider, which will be important later in my talk. So competency work. This has been stated earlier today, but navigators come from a variety of backgrounds. Navigation functions have been performed much longer than the word navigator has been in use. And so identifying who best fits the problem that you need to solve is an important first step. And I would also agree with Dr. Freeman that teams of navigators are most ideal. I know that we're in a resource-constrained environment. That's not always possible. But I'm a big fan of multidisciplinary teamwork, even within the navigation team. Why competencies? Why are these important? They create professional standards and a framework for training. It helps to clarify the function and importance of a particular role to grant makers, to organizations, accrediting organizations, payers, as well as policymakers, as Ron mentioned earlier today. And when we embarked on this work, these were our collaborators. I don't believe in going it alone, really ever. I think that we're always stronger as a team. So we engaged AONN, ONS, NASW, AOSW, ACCC, and navigators on the ground, as well as community health workers in our work. And the first thing that we did was we reviewed all of the community health worker competencies that we could find that were publicly facing, curricula for community health workers that we could find, curriculum from patient navigation trainings that we could find. And overall, we distilled all of these different roles: community health worker, patient navigator, social worker, nurse navigator, with these functions. So across the different navigation types, there's a piece, certainly you need to be adept in communication. Cultural competency is very important. Ethics is very important. Knowledge of community resources, psychosocial support, care coordination, advocacy. These are just some of them, but these are the major buckets that these things fell into. And one point I want to make that I think has also been made earlier today is that navigation types may perform similar roles, but they perform different scopes of practice, right? So the ONS just updated their Oncology nurse navigator core competencies, and they're focused on nurses. These are the areas that they cover: coordination of care, communication, education, professional role, and then there's a section on expert oncology nurse navigators. What we did in 2014 was we actually adopted the structure of the ONS competency framework development, and my focus has always been on the non-nurse navigator. I don't like to say lay because it sometimes is frustrating for someone who's a paid professional who gives their life to a navigation role to be called a lay navigator. So I first called them non-clinically licensed. Now I'm just trying to convert people to say patient navigator versus nurse navigator or some other type. But like I said, we did an environmental scan. We did a comprehensive literature and internet review. We developed a framework with a lot of collaborators around the roles. And then we did focus groups with patient navigators across the country to look at anything else we might have been missing. And then we created competency statements using the framework that we developed and the focus group data. We asked individuals for each of the competencies. First, we met with, or we distributed it to 22 experts across the country, and we asked, do you need clinical training to perform this role? And if anything seemed clinical, we eliminated it, because our goal was not to duplicate what ONS did or to duplicate what any other clinical education program is doing, but really to focus on what someone who is not clinically trained could do as a navigator. And then when we rolled out our survey to 525, a national sample of 525 individuals, we asked individuals to what extent the competency was an essential function for navigators in a wide variety of settings, to what extent the competency was clearly written to facilitate consistent interpretation and implementation, and then overall whether they endorsed the competency. And then we provided an open text field for feedback in case folks wanted to provide feedback. And the other important thing that we did in this process was around the same time the ONS released their original competencies for nurse navigators in 2013, AAMC and the graduate, I always get this acronym wrong, ACGME, Accreditation Council for Graduate Medical Education, produced a paper, basically a call to action asking individuals who are working on competencies to do them within a similar framework so that we're speaking the same language. So what we did was we ended up using the framework that ACGME and AAMC requested, and these were the domains that they advocated for. So basically what this means is, under patient care, if you're a physician, you need to know certain things. If you're a navigator, you need to know certain things, but you need to know something about patient care if you're working in healthcare, right? So each of these domains were advocated for by AMC and ACGME as the buckets, to attach competencies to. And the number to the right of each of these domains indicates ultimately the number of competency statements we ended up with for the patient navigators. So let's take a look. I'm not going to read all of this, but I wanted to provide it to you. When Darcy was talking this morning, I thought, oh, I guess I better put a little bit more detail into some of my slides. So just taking a quick look at patient care, the overall goal is to facilitate patient-centered care that's compassionate, appropriate, and effective for the treatment of cancer and promotion of health. How is this done? Well, a number one goal is helping patients access cancer care and healthcare systems by assessing barriers and engaging patients and families in potential solutions. Another thing is being able to assess and identify credible resources and refer out to those resources. Under knowledge for practice, a general understanding of cancer terms, medical terms, a general understanding of healthcare payment structure and financing, where to refer patients is important for a navigator in practice. Practice-based learning and improvement. Here I'm highlighting contributing to patient navigation program development, implementation, and evaluation. And I will leave you a tool for that in terms of metrics and evaluation. But it is important for navigators to help inform that process since they're the ones that know what's happening in practice. Demonstrating empathy, integrity, honesty, and compassion in difficult conversations. So I'm going to make an appeal at the end that I will repeat, but my appeal is that competencies have been developed and that we need to build on each other's work because we have bigger problems to solve. And this is one of them. It's very hard to communicate. It's much harder to figure out how do we get these competencies into practice and make sure people are skilled practitioners than it is to identify these competencies, right? So one of the things I'm really excited about that my team has moved on to, we are piloting a project called TEAM, which stands for Together, Equitable, Accessible, and Meaningful. And we've recruited 24 healthcare institutions across the country, all of which has some kind of cancer providing service. They had to apply as teams of 4, and they will go through an online training this month that is about 5 hours long, create a systems change. They'll basically do an institutional assessment to look at what they want to change in their system. They'll come to GW for 2.5 days for an amazing kind of blockbuster group of faculty that I've amazingly recruited all around the country just because they believe in what we do, not because we're paying them tons of money. But folks like Jennifer Potter at Fenway Health, Tom Leviste at GW, Kamara Jones, past president of the APHA, and we'll be providing hands-on technical assistance to help each of these systems troubleshoot and think about action steps for their system goals. And then we will track them over 4 months, provide a couple of other TA touch points, and measure their progress. So I'm pretty excited about that, and that's really going to things like patient-provider communication and are we providing equitable care? So that's where I think we should be going. Professionalism, applying knowledge of differences in roles. So this is pretty important, right? Like I said, my focus was on the someone who hadn't been clinically trained. So understanding role boundaries and knowing where your job ends and your colleagues begins is pretty important. Systems-based practice. So here's another point I'd like to make. So organizing and prioritizing resources. We ask navigators to be good stewards of resources. Dr. Pasquette mentioned that they can only provide navigation to those in the breast center that are on Medicaid because of resource restrictions, right? So as academicians, as researchers, as clinicians, we may think that we have unlimited resources, but in reality, we have the same responsibility that we're tasking our navigators with to be good stewards of resources. And what that means to me is working on top of each other's work, working together as collaborators, and including populations we may not have historically included, like sexual and gender minorities. I've been doing a lot of speaking on this topic to different cancer centers, and not including populations in our data, not publicly reporting these data, means that we will never have the information we need to solve the problems we need because the populations just aren't big enough for powered studies to solve all of the problems that we need to solve. So, you know, modeling what we're saying we want navigators to do in terms of stewardship, I believe pretty strongly in that in terms of what we're doing for research. Interprofessional collaboration, participating as part of teams. It's critical that navigators are embedded in teams, that they're respected. We should be looking at things like Tracy's study on implementation. What kinds of clinical factors need to be present for a navigation program to be successful? What factors don't matter? What are critical? And then in terms of personal and professional development, demonstrating healthy coping mechanisms to respond to stress, because these folks are right on the front lines. So how do we make sure that we're supporting those individuals who are supporting our patients? And you know, to Tony and Doris's point earlier, I was thinking about this as they were talking. They were their biggest supporters for each other, right? So how do we assess the support networks of patients so that they can capitalize on whatever support network, which is going to look different for every single patient, right? Which will not only help reduce burnout among navigators, but help provide the tools that folks need to do their own navigation and see the support in their own lives. I wanted to specify a few differences between patient navigators and nurse navigators. This was taken from the ONS, the 2017 ONS navigation competencies. All of these things are common across patient navigators and nurse navigators. And I should state up front that I looked very closely at the nurse navigator competencies when developing the patient navigator competencies, because to me, it's an area of scale, right? Like if you need to know something as a nurse navigator, you may need to know that as a patient navigator with, you know, a slightly different scope and practice. But lifelong learning, effective communication, contributing to and advocating for role, tracking and monitoring metrics, these are all things that both kinds of navigation types should be doing. However, some differences include applying clinical guidelines, knowledge of clinical guidelines, providing education on genomic or molecular testing, or reinforcing diagnosis, treatment options, side effect management. These are things that really someone who's a nurse should be doing, right? So these are some differences between what someone with a nursing license and someone without could potentially be doing. So as I said, I'm very applied. So we took these competencies and we built a 20-hour self-paced free online training, which you can access at our website. What this covers is the core competencies, basics of healthcare and navigation, communication, professionalism, and enhancing practice. And this is not the end-all be-all, but it is a strong foundation. What we wanted to do was elevate the level at which navigators were able to perform by providing a foundation of knowledge. This is not to say that there isn't need for more training, other training, specialized training in different populations, advanced training, but we've reached hundreds of individuals through this training. This has become a core piece of the curriculum for the University of Houston's Bachelor Prepared Social Work program. I just sent the curriculum and all of the slides to the University of Alabama, who wants to adapt it for their pediatric training. It's being adapted in Indiana for mental health navigation for veterans. So it's been, I don't believe in recreation. If we have something that works and there's evidence behind it, let's spend our dollars, our research dollars, and our time solving another problem, because we have a lot of them to solve. These are some other options, though I don't want to give you, oops, I may have gone, did I go too fast? No. These are some other options. So there's a Cancer Navigator program for either non-nurses or nurses. Our training, we have two trainings, one that's focused on navigator competencies and the other for building a program, which is a little different than supervisor training, which was mentioned earlier. This is really kind of needs assessment. How do you plan? How do you implement? How do you evaluate? Those kinds of things. How do you make decisions about scope? Those kinds of things. Dr. Freeman's program. There's a couple of universities that have started to launch certificate programs. There's a native patient navigator training. And there's also the Patient Navigation Training Collaborative in Colorado. We worked very closely with them when we developed our training. I'm very indebted to them for a lot of, they had very solid training, and we went to them and said, I want to make things as broadly accessible to as many as people as possible, as cheaply as possible, so that we can move things forward. So they were really instrumental in the development of our online training. And there's an integrative navigation training through Smith Center, and again, a couple of other university trainings. So this other point that I want to make, there's a big difference between a certificate and certification. So all of the programs I just mentioned provide a certificate. And what a certificate is it says you completed a certain course. You, as a participant, went through certain learning objectives, and you identified, and you were able to get through a particular time-limited curriculum. Certification is typically monitored by a third party. It's usually a proctored examination that is a more objective view of whether a person is able to pass a threshold in terms of their ability and what they know. And so right now there are two entities that provide certification. One is the Academy of Oncology Nurse and Patient Navigators, and there's two options, one for nurse navigators, one for patient navigators. And then the NAPBC provides navigator certificates based on role. So it's only for breast, but they have that broken down based on the type of provider that you are. AONN also just launched some collective metrics. It's a very long document. It's about 100 pages, but if you want to look for some metrics, like what do you potentially want to capture, these are the areas that these are kind of the domains under which they developed these metrics. We developed a GW with support from Genentech. We developed a free tracking tool that's actually based in Excel. It kind of, I think, reached the capacity of what Excel can offer. But we have, there's a place for patient testimonials, there's a place for case management, there's a place to track time points, number of minutes that you've spent navigating, specific encounters, specific barriers, and you can download it. You can use it in your research studies. As long as you don't sell it or try to make money off of it, you can use it. It's also customizable, so you cannot use the fields you don't want to use. So this is our patient barriers and outcomes tool. Whoops. There's how-to videos so that you can access, from a user perspective, you can look at how do I use this tool. And there's also over 80, not that you want this many reports, but because it's Excel, it's pivot-based, there's over 80 auto-generated reports that you can produce by using the tool. We're hoping to work with CDC to make this EHR interoperable, HIPAA compliant, and lots of other things, but right now we don't have funding. So it's in Excel, you can download it, take it as it is. Other resources, we have a big toolkit that has things like group exercises, job descriptions, other things that might be helpful in advancing the field. You can download all of these things from cancercontroltap.org, which I totally should have put up here, cancercontroltap.org, if you go to our repository. And then the roadmap that Nina mentioned, which helps in the creation of the needs assessment process. And I won't have time to go through these very thoroughly, but implementation factors, when you're creating a navigation program, make sure it's addressing a need. Define the role of the navigator, make sure there's adequate resources so that they're not navigating to nowhere. Consider communication, consider operational processes and support. So another thing, how do we get Sarah's protocols and standard operating procedures scaled, right? Like having numerous protocols so that this 45 community health workers know how to navigate someone regardless of the type of screening is amazing. Like that's the kind of work that we need to be doing. How do we scale that? And how do we create these cultures of quality improvement so that we can knock out the problem and move on to the next issue? Again, I'm not going to read these because I've run out of time, but we want to know who our patients are, where the bottlenecks in the system are, and now I'm forgetting who had that map. I think it was Melissa who did the environmental scan and looked at all of the ways that the patient's experiencing care and making sure our services are matching needs, asking providers, thinking about clinical workflow considerations, but ultimately, what problem are you trying to solve? You know, I mean, people say navigation is, you know, what metrics should we be capturing? Well, it's tough because navigation's been used for so many things, but at least being clear, what are you trying to solve for your population at your institution is really critical. Again, I won't go through this, but just thinking about the patient's process across their journey. How do we make it simpler for patients, easier for clinicians, and maximize the productive time that clinicians have with patients? What exactly do we want navigators to do and not do? How do we want them to work with their colleagues? And don't hire a navigator to fix the wrong problem, right? We have to know what it is we're trying to fix and not say that we're doing navigation in place of trying to create more efficient systems and you know, pretending that putting a navigator in an under-resourced system is going to create equitable care. Again, I'm going to, since I've run out of time, I apologize, but you have these slides. Hopefully they'll be sent out. Just considering how is the navigator going to access, interact with the patient, communicate with payers, and do supervisors have adequate time to support and troubleshoot challenges that navigators face? Speaking of supervision, I was really happy to hear Sarah's three-prong administrative, clinical, and reflective supervision that she mentioned. I think that's a great model to think about. Creating care maps for common problems. You know, if we can create solutions and system solutions so we don't have to recreate the troubleshooting every single time. And then creating a culture of quality improvement. So in my humble opinion, that's what I think we should be focused on. These are my references and that's my contact information. So happy to take questions, and I'm sorry I went over a little bit.